Hello, I'm Jerry Sefton. I'm an advanced nurse practitioner working on the paediatric intensive care unit at Alder Hey in Liverpool. Over the last 10 years I've been studying acute deterioration in children in hospital, and today I want to share with you some of my experience about deterioration in children with complex health needs. So the challenge for us working in hospitals with children is to try and identify early those subtle signs of impending serious illness or deterioration to try and prevent a serious adverse event. These include respiratory or cardiac arrests, unplanned emergency admissions to the intensive care unit, or unexpected deaths. Thankfully, these instances are rare, only accounting for 1% of all hospital admissions overnight. But you can imagine the challenge for the clinicians. It's akin to looking for a needle in a haystack. So the consequences of getting it wrong are immense. If a child deteriorates in hospital to the point of having a cardiac arrest, only half survive to hospital discharge. And of the survivors, a quarter are left with a significant brain injury. So this is catastrophic for the child and their family. This is also devastating for the hospital staff because they've been unable to protect a child in their care from coming to harm. This can be very upsetting for them. There is also a significant financial cost to the hospital. In a recent health economic analysis of paediatric cardiac arrest in hospital, they costed the resuscitation event at £4,000 per case, in addition to normal hospital costs, and the care of a child to hospital discharge post-arrest at £54,000 per case. In addition to this, the NHS faces litigation costs annually for suboptimal care, and in 2012 to 2013 that was £1.1 billion. So all in all, failing to spot and act on the early signs of child deterioration carries significant negative impact on NHS costs. We also know that over 5,000 children a year are admitted to ICU who were already inpatients in hospital. Those children have deteriorated, not quite to the point of having a cardiac arrest, but are still seriously ill. Those children have an increased mortality risk, twice that of any other child admitted to the intensive care. And of the survivors, a fifth of those have got an acute brain injury. So if we could improve our ability to identify and act quickly at those early subtle signs of deterioration, those outcomes for sick children in hospital could be improved. So we have a case series from Berg and colleagues in 2010 which looked at the prodrome of cardiac arrest in children in hospital to try and identify what are the early signs of the child becoming more unwell before they had a cardiac arrest. And interestingly, they found that in 92% of those cases there were signs present. The most common signs were breathing difficulties or breathing insufficiency, poor perfusion and altered neurology. So these are key signs to look out for when you're considering if a child is deteriorating. In my own hospital in 2009, we did a case note audit of all children that had cardiac arrests. We looked at their vital signs for 24 hours prior to the arrest event to try and understand if our current early warning system was able to predict those children early. We found in half the cases that the early warning system did pick up those children as deteriorating, but in 18% of cases it was the nurse recognising that the child was unwell that raised the alarm. The remaining children deteriorated quite quickly, mainly with alterations to heart rhythm and problems with airway devices like tracheostomies. So it's important to realise that paediatric early warning systems are a useful adjunct to patient safety, but currently are not very well configured to children with complex needs. Clinical judgment is key. Nurses and doctors have trained for many years, and it's important that they hone and develop their skills so they become more adept at recognising and acting quickly when children are starting to deteriorate. So in my experience, I would say all sick children are not equal. Young children particularly are quite dependent. They cannot verbalise when they're becoming more unwell, and they rely on reasonable adults to notice those subtle signs. There is also the challenge that there's significant variation in heart rate and respiratory rate with age, which means that the norm that we accept varies quite markedly from young to adult. We have to remember that children also present to the hospital at varying stages in their illness trajectory. Some may present early when they're able to still compensate for becoming more unwell, and other children may be presenting late where they've already started to decompensate and we have less time to intervene. It's also important to realise that vital signs are affected by underlying illness. So for example, in children, particularly babies with heart problems, they breathe faster than other babies and their heart rate will normally be faster than other babies. And when they become unwell or get a chest infection, they actually are quite fragile and deteriorate very quickly. Also, we know in children with brain injuries, their ability to regulate their temperature is altered, and often they're quite a lot colder than other children. And even having a minor raise in their temperature could mean that they're quite sick. We're able to describe also from our experience of studying this, certain groups of children that are higher risk of deteriorating than others. Through our years of studying acute deterioration, we've been able to identify groups of children who are more at risk of deterioration than other children. And it's important to be aware of the hazard they pose. These would include children that have been born prematurely. And as a rule, the more prematurely that you've been born, the more likely it is that you will deteriorate quite quickly. Those children have limited ability to adapt when they're becoming unwell, and that stays with them really for the first year of their life. Also, we know children with heart problems, particularly cyanotic heart problems, also have limited ability to adapt when they're becoming unwell, particularly if they've got breathing problems. We know that children that have been undergoing treatment with chemotherapy and radiotherapy, that their immune system is suppressed, and those children can become very unwell very rapidly if they get an infection. So if you have a child in your care with a problem like this, you have to take them very seriously. Also, children with profound neurodisability who are totally dependent for all aspects of their care have an increased risk of deterioration. And that really is for several reasons. One is they often have an impaired ability to swallow, and they can easily aspirate their food or drink or even their saliva and get a chest infection quite easily. Also, when they're becoming more unwell, clinicians sometimes assume that the neurology that they're seeing is the child's normal state, and they find it hard to make a judgment about how well the child is. Also, we know that children that have previously been admitted to the ICU have an increased risk of being readmitted to ICU for the 6 months afterwards. It's important to also remember that acutely ill children are not located in one geographical area in your hospital. They could be anywhere on any ward, so we have to have heightened suspicion when we're looking at children that they might be in the early phases of deterioration. So it's easy to have 20/20 vision in hindsight and say deterioration should have been picked up earlier. But my key advice would be that we should start looking at all children with suspicion that they might have the potential to deteriorate, and to get better at recognising those common patterns. If you're concerned about a child, I would say go back and re-review them, because you often need a number of assessments to consider the trend of how the child is doing. I would advise staff to take a more proactive approach and to have considered their plan A, B and C if a child is beginning to become more unwell, to improve their communication skills so that all members of the team are aware about their concerns so that a plan can start to be put in place, and also to speak up early to your senior colleagues so that you have support in dealing with these events. I would say for nurses particularly, it's very important to do a full assessment of the child on admission, including blood pressure and a rapid neurology assessment. You have to step back from the patient and make a judgment about, does this information fit the clinical picture that you've been given? And if it doesn't, you have to ask some questions about what really is going on here. It's very important to talk to the child's parents and family to try and understand how this compares to the child's norm. And that will help you in judging how serious this change that you're seeing is. And also, if you're still unhappy about the child and you want a second opinion, it's very useful to speak to the nurse in charge of the ward, who can come across and give a second eye or a second judgment about the child, and can help in getting an escalation plan in place if the child continues to be a concern. I would also give similar advice to clinicians, but they have an added layer of complexity in that they're trying to manage the care of a number of children and a number of wards and try and decide which child's care needs to take priority. I would say that they have to maintain their objectivity, and if what they're seeing doesn't quite fit with the clinical picture, they have to go back and think about differential diagnoses, because the working diagnosis the child has been admitted with may not end up being the diagnosis that they absolutely have. And it may be, as time goes on and more signs and symptoms become apparent, the diagnosis will be proven to be something else. So you need to keep your horizon broad. So as with the nurses, it's important that you verbalise your concerns so that other members of the team know what you're looking for and can look out for those subtle signs and make you aware if the situation changes any further. So in my hospital, we found it very useful to put some teen training in place that uses real cases of children that had deteriorated in the hospital. This is to help the junior doctors and ward nurses to begin to get improved skill at recognising common patterns of deterioration in children and to try and think ahead about what other information they might like to know or what actions they might take to try and improve the care of that child. So we used real cases that have been anonymised for the purpose of teaching. So the case notes are anonymised and all the charts so that the staff can work through the information that they're presented with in a systematic way so they become more adept at recognising these early subtle signs and planning what they might want to do next. So in conclusion, I would say having a paediatric early warning system is useful, but it's not the holy grail. Staff still have to use their clinical judgment, particularly in children with complex needs, to try and identify when they're beginning to deteriorate. I would say it's very important to identify your high-risk patients. These are your known knowns. These are the ones you know that have got a heightened risk for deterioration and you should take them seriously. It's also very important to engage the parents as partners, as allies in trying to help you identify those early signs of deterioration. They're experts in their own child and can provide very useful context when the child is becoming more unwell. Hospitals also need to work on improving organisational safety, so it's easier for staff to do the right thing and also to escalate their concerns if things are going wrong. In summary, I would say keep calm, be systematic in your approach and in your documentation, and be prepared for potential disaster. So if we become more adept at recognising those early signs of serious illness or deterioration in children in hospital and acting quickly, we should see a reduction in serious critical events. I hope you found that useful. If anybody wants to contact me with questions, please email me. Thank you.